Dear audience, dear chairs, dear colleagues, good morning, and thank you very much to let me introduce my PhD thesis about the novel treatment of advanced urothelial cancer. I am Mohammed Altenni, and I'm working at a Peterfi hospital as a urologist. My supervisor, Tibor Sarvas, my scientific methodology supervisor, Jakub Hofarica, and my statistician, Peter Feiervári and Mikol Bakarny. My vision to serve bladder cancer patients with compassion, professionalism, and integrity and excellence. And my mission to provide outstanding clinical treatment for patients with urothelial cancer in a strong academic environment. According to this, I have two ongoing specific goals, both of them about the same disease with a different kind of novel treatment. My first project about the enfortumab vedotin, which is an antibody-drug conjugate binding to the Nectin-4 and causing cell death. So my first project is identifying patients who would benefit from enfortumab vedotin in advanced urothelial cancer. A little bit about the background here, that 5-year survival for metastatic urothelial cancer is very poor, and the advanced urothelial cancer patients are undertreated. Less than 10% of them will receive the third-line therapy. According to the EV301 randomized control trial, enfortumab vedotin is approved as a new third-line therapy. As we can see here, that enfortumab vedotin have a superiority in overall survival and the objective response rate than chemotherapy. The problem here that in a randomized control trial, the patient have a strict eligibility criteria, and in a real world, the patient are less selected. And it's still unknown which patient will benefit from the novel treatment. So our aim here to identify which patient with advanced urothelial cancer will benefit more from the novel treatment. With the clinical question, how do different clinical parameters impact the outcomes of EV-treated advanced urothelial cancer patients? We have a population that patients with advanced urothelial cancer treated with enfortumab vedotin, and we are comparing a different patient characteristics, and our outcomes would be the overall survival, progression-free survival, and the radiographic response. We hypothesize that enfortumab vedotin provides greater benefit to advanced urothelial cancer patients with the specific characteristics. We conducted a systematic search in 3 main databases, and we used the search key you can see below. We got more than 1,600 articles, and after the selection procedure, we got 17 eligible articles. Here, our ongoing analysis, and we already got analysis according to the objective response rate by the RECIST criteria 1.1. So here I would like to present my first forest plot. The objective response rate were compared between the ECOG status. So we have a ECOG 0 or 1 and ECOG above than 1, and we have 9 studies here with the low heterogeneity among these studies that indicate the patient characteristics across this study was similar. The odds ratio for this is 1.88. That means patients with ECOG 0 or 1 have a higher response rate than patients with ECOG above 1. And this result is statistically significant and clinically highly relevant. The second one, objective response rate, were compared between patients with having a tumor location in the bladder and with patients with tumor location in the upper tract urinary. And the heterogeneity among these 10 studies is also low, and the odds ratio is 0.82. That means patients with upper tract tumor location we can say that the relevant clinical significance, and statistically our result is not significant. The third one, we are comparing the ORR between responders and non-responders for previous immune checkpoint inhibitors. We have a low heterogeneity also, with the odds ratio is 1.55. That means patients who responded to the prior immune checkpoint inhibitors have a higher response rate than patient not responded. And these results are statistically significant and clinically relevant. Here we have a summary table of our results. We have more than 15 results according to the objective response rate, and we have some of our results are statistically and clinically highly relevant, and we have studies with no statistical significance. So the strength of our study that this is a first systematic review and meta-analysis with the large sample size, and the limitation we are using univariable analysis, and the patient-level data are unavailable for all studies. We have an implication for practice that enfortumab vedotin is effective not only in bladder cancer, but also in the upper urinary tract tumors. Enfortumab vedotin is more effective in chemotherapy, and in previously patients treated with chemotherapy and immune checkpoint inhibitors. And the implication for our research that the background of differential efficacy of enfortumab vedotin between various clinical or molecular subgroups needs to be evaluated. This is our first project progress. We already finished the risk of bias assessment, and we would like to start the manuscript part. My second project about identifying patients who would benefit from immune checkpoint inhibitors in advanced urothelial cancer. A little bit about background here that immune checkpoint inhibitors are novel standard treatment for patients with advanced urothelial cancers in 2017, and 25% of patients will benefit from this therapy, but unfortunately 75% will not. So our aim here to identify which patient with the clinical parameters are associated with better response to immune checkpoint inhibitors. With the clinical question, how different clinical parameters impact the outcomes of immune checkpoint inhibitors treated advanced urothelial cancer patient. Our population patient with advanced urothelial cancer treated with immune checkpoint inhibitors, we are comparing different patient characteristics like equal liver metastasis and lymph node metastasis, and our outcomes overall survival, progression-free survival, and objective response rate. We hypothesize that immune checkpoint inhibitors provides greater benefit to advanced urothelial cancer patients with specific clinical parameters. Our clinical implication to provide clinical guidance on which patient will benefit from immune checkpoint inhibitors. We conducted a systematic search in 3 main databases, and we have more than 3,000 articles, and we use the search key you can see below. We have more than 3 key articles. The most important one is submitted by Melinda Vardy from Semmelweis University Urology Clinic at the end of 2023, and it's a retrospective real-life study with a big sample size. To sum up my projects, I have 2 ongoing projects. The first one about the enfortumab vedotin, and we would like to submit in May. The second one about the immune checkpoint inhibitors, and we would like to submit in August. I would like to thank you for your attention by my favorite quote, to be brave to stand for what you believe in, even if you stand alone. And thank you for your attention.
Congratulations. I have 2 questions regarding your first topic. The first question is enfortumab vedotin is available in Hungary? And the second one, is there any study which use enfortumab vedotin as a first-line therapy?
Thank you for your question. It's a good question. So the enfortumab vedotin in Hungary, they will start using it soon, as of my knowledge. And at the end of 2023, the FDA approved the using of enfortumab vedotin with a combination with immune checkpoint inhibitors at the first-line therapy. It was approved at the December 2023. So,
Thank you.
Congrats for the presentation. I also have a question for your first project. What about the side effects of the patients that had a history of checkpoint inhibitors compared to them with chemo only?
So thank you for your question. If I understand your question rightly, that you're asking and the side effects of immune checkpoint inhibitors in comparison with
The prevalence of the side effects was higher for the patients with a history of checkpoint inhibitors as compared to those who had only chemo and no history of checkpoint inhibitor.
At the literature for patients with advanced urothelial cancer who treated with chemotherapy have a higher adverse event than immune checkpoint inhibitors.
Okay,
So
there is no cumulative effect in time.
I don't think that just 25% for those patients will receive the immune checkpoint inhibitors, and this is a very low number with acceptable adverse event. But for chemotherapy, there is a high rate of adverse event.
Thank you for your presentation. My question is regarding the second project. Do you have any plan how you are going to manage the characteristics? Are you going to subgroup them?
At this moment, yes, we would like to do a subgroups for the second project. We are in the beginning of the project, so we would discuss it with the statistician, but we would like to include subgroups also.